I am Shannon Weber with HIVE at the Bay Area Perinatal Aid Center, and I'm here at the 5th International Women and HIV Symposium.
Yes, hello. I'm Dr. Jesleen Rana, and I am a very new physician, HIV primary care physician and an addictions worker, working specifically with women in Toronto, Ontario. It's a pleasure to be here.
Yeah, I'm so glad we met. So this whole concept of trauma-informed care is a new theme that's coming out as it relates to women, particularly women in HIV, but I don't know exactly what that is. So can you tell me, what is trauma-informed care?
Absolutely. It's interesting you say that it's coming out now. It's actually been around for quite a while, but I agree with you. It hasn't been at the front line of care for women because, as we know, a lot of our research, a lot of our literature, a lot of our approach to care has often been very paternalistic, and we're starting to see a little bit of shift in that, which is a beautiful thing, especially when working with women. So what trauma-informed care is, it's an understanding and an approach to care with men or women, understanding that trauma exists for men or women. It's just an understanding that stemming from childhood all the way into adulthood, experiences of trauma, help or shape a person's life narrative, and it shapes the way they deal with their life circumstances. And without acknowledging that trauma in their life, we're missing a key piece to addressing their sense of well-being, or if we look at their social determinants of health, we're kind of missing a big gap if we fail to acknowledge trauma and what its profound impacts can be on health. And so having a trauma-informed approach to care is not necessarily meeting someone and being like, let's talk about your trauma, but it's about understanding that, okay, especially when working in the context of HIV, especially with substance-involved individuals, or even in people who are HIV negative and are substance-involved, understanding that, without exploring trauma, we may not be understanding some of the root causes of where substance involvement comes, or certain sexual practices come from, in terms of
your vulnerability to
exactly
HIV or unplanned pregnancy or all of these things.
Exactly, yeah.
And so then how does this trauma-informed care overlap with your addiction work?
Well, it's a huge part of working with women who are substance involved. I do a lot of work with women who are involved with opiates, whether it's taking it by mouth or intranasally or via injections. And what we know, and what we've known for quite some time, is that the reason that women use and the reason that men use are not always the same. Sometimes there's an overlap, but sometimes there's different life experiences. And so one thing we do know is that trauma plays a really big role in why a lot of women start getting involved with substances. And now trauma doesn't have to be physical trauma. It could be, something like abandonment in childhood. It could be something like a sense of, experiences in adolescence. It could be physical, sexual, emotional violence or trauma. And so it doesn't have one shape or form, but we know that with women who are substance involved, that's often very deeply embedded in their life experience, that it leads them to where they are at their point in life.
Often multiple experiences.
Often, yeah. I mean, it's very rare there's like an incidental. It's usually like continual in different shapes and forms throughout life.
And you mentioned to me earlier this piece about the system reinforcing or triggering the traumatic experience, because the systems that we create can have trauma embedded in them. Can you talk a little bit about that?
Yeah, absolutely. Well, we know that for many reasons, medicine has often been had a very anti-feminist and paternalistic approach to research and to care models, and women have been labeled as atypical, or we know that it's been very paternalistic in terms of practices and research. And so a lot of really well-intentioned physicians just don't have the information, because the information that's out there is not necessarily accurate. So if you actually read a lot of the literature about women who are substance involved, you'll see that women are quoted as being less motivated or less willing to engage in care, and all these factors that are put on the women, whereas and so as providers we read that, we go, oh, okay, women are less motivated. But actually, if you take a step back and you look at the system, you realize that the system itself can be very traumatizing for women. So I'll give you an example. So if a woman is recreational heroin user, and she injects and has an overdose, and she ends up in a hospital bed, and she was agitated, she's in a 4-point restraint. That can bring back a lot of trauma from, you know, previous experiences in the past, and so then a sense of mistrust can often develop, and often re-engaging in care can be re-traumatizing for women. So it's not that they're not motivated, it's not that they don't want care, it's that engaging in care can be very traumatizing. So, you know, and like I said, often it's like very well-intentioned physicians, and, you know, it's just, we have to take a step back and realize that, you know, even the literature that is considered to be strong literature, we have to have a little bit of a critical, you know, feminist framework and look through, and lens to look through it as well.
Yeah, that's one of the things I'm hearing from you. The theme is looking at it from through the woman's eyes, or from her perspective with this, you know, over her lifetime.
Absolutely.
You had talked to me about this narrative approach, which is a new way, or at least it was new to me, of looking at healing or approaching women in care. Can you tell me about that?
Yeah, absolutely. It's something I'm discovering and I'm learning as I go, and it was actually introduced to me by a trauma-informed counselor who I work very closely with, and what it is basically like there's different approaches to trauma-informed in care. So, you know, traditionally there's scenarios where you work with the woman and you talk about the instances of trauma, and it's about confronting the trauma and having a sense of empowerment walking away from it. But that in itself can also be a little bit traumatizing for the women often. And so what narrative therapy is more like, okay, we don't have to focus on the instances. We know that those are embedded in the woman's sense of self, but what's kind of the positives that's come out of that? So you look at her, you know, ability to survive. You look at her incredible resilience. You look at her ability to, you know, care for her children in an environment that is so against her, and you know, and so it's a narrative approach to trauma is kind of looking at her life story and saying like, okay, that, you know, these things happen to you, but like, let's look at you now. Look at where you are. You're here with us. We're here together. Like, and you look at the you know, the survivor skills that come out of that.
Yeah. So identifying her coping skills and the strengths-based approach.
Exactly. Yeah.
Which is beautiful. Okay. So now I'm intrigued. So let's say I'm a social worker. I'm a nurse. I'm a doctor. I don't know when I'm going to get to a trauma-informed training, but I want to do a better job. Could you tell me one or two things that I could do differently in my practice?
Absolutely, and I love that you asked that question, because I think everyone working with women, even if they don't have time to get formal training, should have an understanding that without addressing trauma, there's often a sense of void and distance between providers and care and the individuals. So it's not like you have to bring it up immediately, but you have to, you know, just bring it up with women, saying, you know, often life experiences, and that can be traumatizing, shape who you are, and we don't have to talk about them, but understanding that that at least addressing it opens that door for the woman. And the other thing is understanding that care for women who have had trauma in their life, it's never linear. It's very sporadic. It can be up and down. And as providers, you know, we can't take that personally. We have to look into being more flexible and being more understanding that there are times where she has to be ready to engage, and there will be times where she's ready to talk about it, and then, you know, the next day she's not, and that inconsistency is not a sense of lack of motivation or lack of interest in being involved, but more so, you know, part of the process. So as providers, you know, if our patient doesn't show up for her appointment, rather than, you know, being like, okay, here's the bill for, you know, $25 because you wasted my time, understanding that, okay, she needs to have, you know, we need to have some flexibility and some
right. It's like being able to meet her where she is when she's there, or
yeah. And you know, like, of course, like, there's a partnership, right? So the women have to engage, and there has to be a sense of onus on both the provider and the woman. So it's not like, you know, every time you open up slots every day and she doesn't show up, but it has to be about a narrative, about being like, let's create a space where, you know, you can come in and talk, but there's a sense of responsibility. I'm showing, you know what I mean? So there has to be a transaction both ways, but understanding that it's not linear and it's not always like, you have to have a bit of flexibility.
That's really beautiful.
Thanks.
Thank you so much. I can't wait to learn more. You're amazing.
Oh, thanks for having me.
You bet.